South 18th. He was at the South 18th clinic seeing patients there, and he transitioned, as you all know, that's one of the satellite clinics. He transitioned onto the faculty of the residency program in 2011. So he's fairly new as a faculty member, and I've really enjoyed every single opportunity I've had to work with Dr. Hess, and so I've asked him to come and talk about primary care from his perspective. Okay?
All right. So I understand that you guys have had a lot of input regarding primary care. So I thought I would kind of take the temperature a little bit, and we can try to pull everywhere, and see where your understanding is regarding which of these is a primary care specialty or which is not. So if you just text a code to 37607, and we should get a little bit better idea of what your understanding of primary care is. So let's see if this thing works. Okay, there we go. One.
Oh, I think I called it. Who's holding out?
I misunderstood the whole concept of what we were doing, so just give me...
Do you have a phone, Jay?
Yeah, I do have a phone. I wasn't aware that... I thought we were doing something different.
Okay, stay with us. Okay. So if I can do it, you can do it.
Okay.
So you dial 37607, like it's a number.
Yeah.
And then you put in that number.
Yeah, I
got it.
Don't worry about what I did. Okay. Well, now it's going to be so obvious when I'm not going to do this one. I'm not going to do this one.
Moving on.
So we don't have any markers, do we?
Katie has markers. Dr. Barron stole them last time. It's not stealing if you give it back.
We got 9, so I guess we have 2 more, or we have 2 who are abstaining.
There's some abstention.
Abstaining.
Pleading the 5th. All right. So why did you guys pick, most everybody obviously picked OBGYN. Tell me why you picked that.
Because it's Dr. Barron's story.
I think I did say that.
I'm sorry, so bring me up to speed here.
So I remember speaking with Dr. Barron a while ago, and she was in her clinical rotations, and I think she was very highly placed at the OBGYN, and she chose family medicine and kind of got scorned for that.
Yeah, I did. That was a story. It was a story I told that scarred me for life, so it apparently made an impression.
Okay.
If you're an idiot, you'll always be a second-class citizen if you do family medicine.
Okay. All right. So why is OBGYN not? And that's the right answer. But why is OBGYN not primary care?
There may or may not be certain segments of the human species that are lopped off.
Yeah.
That's right.
So it is it's gender specific.
It's usually not the first person you see for a problem.
Okay. Both.
I'd say the majority of their work is limited to a pretty specific age group.
Mm-hmm. Good. Some age group specific. Although you do have pediatric oncologists.
Right.
All right, well, those are good places to start. I'm going to use, this is the handout for the talk. This is a talk I gave to the medical mentors class, I guess, group a couple weeks, 3-4 weeks ago. Were any of you guys there, by any chance? Okay, Laura was there. And I'm not going to give the whole talk. There's a lot of detail in it, and I really don't want to go into all the detail here. But I'm going to start by just talking a little bit about some of the definitions or what makes primary care. And this hopefully will be something of a review for you. So the Institute of Medicine is this think tank up in Washington that has given us some very helpful definitions. And they've defined primary care as the provision of integrated, accessible health care services by clinicians who are accountable for addressing a large majority of personal health care needs, developing a sustained partnership with patients, and practicing in the context of family and community. So that's a big, wordy definition, and it's kind of dull, and I might fall asleep halfway through that thing. So we want to break it up a little bit here and look at each portion of that definition. So first of all, primary care is integrated. This means it addresses a broad range of medical needs from a variety of different angles that usually will include a physician, but it can also include other care providers, nurse practitioners, PAs, social workers, ideally all of them working together as a team to care for patients. And just stop me if you have any questions as we go along. It's not going to bother me, and it's not going to disrupt the talk at all. So primary care is also accessible. This means that a patient can communicate with their care provider easily and be given an appointment to be seen in a timely fashion. What do you think about that in terms of communication? One of the things one of the buzzwords that we hear a lot is this phrase, open access. Has anybody heard that phrase used? There's a Scott and White billboard that says something about open access as you're going south towards Temple. I don't know if y'all have seen that or not. What would it mean to you to have your doctor accessible to you?
To have a line of communication outside of the doctor's office.
Mm-hmm. And are you familiar with what kinds of, and that's exactly right. Are you guys familiar with what some of those things are?
Email.
Email, right. Are there any problems that we can anticipate with email?
Too many of them.
Too many of them? So if you're on the receiving end of those, you may get inundated with emails. What are some other issues that can arise with emails?
You don't have access to internet?
I'm sorry?
If you don't have internet access?
True. So if you're limited as far as your access to technology, you may not be able to access your physician that way.
Confidentiality?
Confidentiality, yeah, that's a big one. Big issue, and probably the major issue. So we've developed some workarounds in the medical profession for that. One of those is something called a secure patient portal. Many electronic health records now have a secure patient portal built into their system. So you can actually sign up for the portal, and then you can go in from any internet point of access your patient web portal, which is secure, and then communicate with your doctor by sending a message through that. And we actually, at the Family Health Center, we have that. I think Dr. Barron mentioned that she's shown you that our EHR, our electronic health record, which is called Epic. And within Epic, we have this secure patient portal called MyChart. And all the patient has to do is log on from any computer, and and they can send a message to their care provider. It doesn't necessarily get read right away, and that can be an issue. So we always encourage folks not to send urgent or emergent messages to us through that mechanism. But if they have routine questions that can be answered, or for which the answer is not obligatory within a very short time frame, then we'll encourage folks to access us that way. It actually is pretty helpful. It has reduced the burden on our nurses. It's improved communication because we're not communicating to somebody who's then re-communicating to the patient. We're able to communicate directly with the patient, and there's an increase in patient satisfaction with that, and you're able to, as a physician, address a lot of those needs in fairly real time, actually. And initially you think, wow, I'm going to get inundated because some of my patients are really challenging and they have a lot of questions. But that tends to be offset by the degree of satisfaction that your patient has in terms of their ability to contact you. Have you had some
Since
experience
I've
with that?
flown, I haven't had much experience with it, and but I've wanted to, and I've actually signed up for it for our family. I haven't used it much, and I need a private lesson in how to release results to my chart and things like that. I find myself being apprehensive too in terms of just being eternally, accessible.
Right.
But my suspicion is there's maybe a little uptick, and then once patients are sort of reassured that they can, it really works, then it might trail off a little bit.
Right, and I think that's true. We had one of our physicians went ahead and signed up one of his most difficult patients for the electronic patient portal, and he was surprised after a few. I think he had 5 or 6 in a very short time period from the individual, and he answered each question fairly promptly. And over time, that individual's satisfaction with the system grew. She stopped calling repeatedly because she had been calling the nurses over and over and over and over and over, and she knew that email was going right to her doctor, and that he was seeing it and responding back to her. And so there was decreased frustration on the part of staff because they didn't have to deal with her complaints and the persistence with which she was calling. And it also made her feel like she was getting much more immediate access and support from her physician. So it was a win-win for us in this situation. Primary care providers are also accountable for developing a sustained partnership with patients and practicing in the context of family and community. And this is the famous continuity of care that we talk about that's so essential to primary care. And that really, I think, speaks to the earlier question on the poll everywhere, why OBGYN is not a primary care specialty. Because we're talking about episodic care, we're not talking about continuity of care. We're talking about, and when I say episodic, I'm saying that a woman is going to go to an OBGYN for really one of 2 reasons. One, she's pregnant, or she has a specific gynecological medical problem. And there are a whole host of other medical problems that can play into those. But the gynecologist or OBGYN is not going to be addressing diabetes, high blood pressure, cardiovascular risk, neurologic disease, connective tissue disease, mental health issues. And that's where pediatrics, general internal medicine, and family practice really derive their meaning and their purposes from being able to address those issues in a longitudinal fashion. Pediatrics to a lesser degree, and internal medicine to a lesser degree, obviously, because pediatrics is going to cut off around age 18. Internal medicine is going to pick up at that point. Family medicine covers the breadth of patient need across the age spectrum. Questions about any of this? This is the biopsychosocial model of health. Some people use or posit a biopsychosocial spiritual model of health, which would put a spiritual element in there, and I think that's very appropriate. However, this is the most common model that you'll see discussed in the literature, and so it tries to take into account the biological, social, and psychological aspects of the human being with all of these different issues and some of the overlap there. So, you know, for example, trauma, whether it's physical or emotional, can affect the social aspect of things. That affects mental health, which then has an impact on your overall biological function. So this diagram attempts to show how we as human beings are very complex and how there are a lot of interrelated effects on different aspects of our personality and souls from these different points of access. Have you guys seen this diagram before? And then this is just a map of the United States showing where we need primary care. So all of those red areas, this is actually by county. So the dark red areas are areas where there's been an identified need for additional primary care. So you can see that we need primary care across the country. Now I'm going to skip ahead because that's just a little bit of an introduction as to what primary care is. I know you guys have talked some about healthcare reform. You're familiar some with the Affordable Care Act. And one of the aspects of the Affordable Care Act is the patient-centered medical home, which is come to the fore recently in political discussions and in primary care discussions as well. It's a controversial topic, and not everybody agrees that it's what we need or what we want. However, it's one of the major pillars of the Affordable Care Act. So it's something that's not going to go away, and it's important for you to be aware of it, even if you don't necessarily agree with all of the aspects of what is contained within the concept of the patient-centered medical home. So let me speak forward here in my presentation. But how many of you, can I just show of hands, how many of you have ever heard of the PCMH or the patient-centered medical home? Okay, so a fair number of you. Tell me what you've heard.
Oh, come on now, don't, you know, make it.
So what have you heard, Laura?
It's just shifting everything around, focusing on the care of the patients and I guess more integration from different types of aspects of care and then
Okay.
kind of all coordinating in one.
Right, so we're talking about coordinated care that is patient-focused. That'd be a good way to summarize what you're saying.
Mm-hmm.
How about you?
I feel like it's more about treating the entire body as one, like treating, you know, physical and mental aspects of the person and not doing, you know, send to one specialist and then another specialist and another specialist. It's more focused on treating the entire person
So
and a lot about preventative care.
It's integrated. Versus atomized.
Great word.
Okay, good.
It's more teamwork oriented
Okay.
between trying to, I guess it kind of goes in with the coordinated care of between the PAs, nurse practitioners, physicians, of bringing effective and efficient care.
So care team delivers care to the patient.
I guess you could also tie in what you were just talking about, the electronic medical records and email correspondence and the integrated care being a part of that.
How many of you guys how many of you guys have the intention of going on to medical school? So pretty much everybody here. So tell me what you, what would you intuit would be the physician, sort of our classic perception of who the physician is and the physician role.
Head of the team.
I'm sorry?
Like the head of the team.
The head of the team. Is that the sort of the the way it has been?
Like, yeah, that's like the way it has been. Like you view the physician as like being number one, or like the person to go to. I don't know. I'm not sure that patient-centered medical home, it's set up that way.
Right, so the head, but not necessarily of a team.
Right.
Kind of like
Just
the
like,
boss.
Mm-hmm.
Yeah, just autonomous.
Not a, yeah,
The
just.
captain of the ship.
Mhm.
Kind of thing.
How about, somebody said autonomous. So you've got the physician as the autonomous boss, sort of, versus maybe a head coaching role, rather? Does that seem fair?
Mhm.
And that's a little bit of a challenge for us as physicians who are sort of trained under the old model where we kind of expected to do everything. You know, it's something of a relief, I think, for many of us to say, hey, I don't have to know everything, but I can help coordinate care and help connect patients to people, to care providers, social workers, nurses, mid-level providers who can help to facilitate care in different areas, and even specialists. So many of us, I think, are excited about the prospects of working in this kind of model, because I think ultimately we're going to take better care of our patients. And that's really why we all went into medicine, or ideally why we're all going into medicine in the first place, is to care for people, to serve them, to improve their lives and their health out of a sense of vocation to that particular service. So let's, hopefully this link will work. This is a little bit of a dated video on the PCMH, but it's produced by the American Academy of Family Practitioners, and will give you a nice overview of what it's all about.
The American healthcare system is in crisis. Costs are skyrocketing. The number of many high-quality care is out of reach. Nearly everyone agrees reform is needed, and a key part of that reform must be a renewed focus on prevention and primary care. That's why a new model of healthcare delivery is taking shape. It's called the Patient-Centered Medical Home. A patient-centered medical home is a place where patients have an ongoing relationship with their doctor, a doctor who knows them and coordinates all of their care. Here, a team of healthcare professionals focus on prevention, employ the latest information technology, and manage care to eliminate repeated or unnecessary tests. Using electronic health records, e-prescriptions, same-day appointments, and comprehensive chronic disease management, the patient-centered medical home ensures better health outcomes, all while holding the line on costs. The American Academy of Family Physicians and TransferMed set up 32 demonstration projects across the nation. The change has been dramatic, and the public is responding.
The doctors here take more time to get to know you and actually listen to what you say.
It definitely makes me more comfortable to know that one person knows my history.
In a patient-centered medical home, doctors spend less time on administration and more time with patients.
She comes in, does not have her hand on the doorknob, going out within a second, so we sat and talked for a long time.
Email communication and consultations over the web are revolutionizing the relationship between doctor and patient. In the current healthcare system, the patient experience is often uncoordinated, fragmented, and difficult to navigate. But this new model coordinates care, manages chronic disease, and is getting real and measurable results. Using some of the best practices of the patient-centered medical home concept, Pennsylvania's Geisinger Health System reduced overall costs by 7% and emergency hospital admissions by a full 20%. IBM brought down individual healthcare costs by 15% and improved quality. And in North Carolina, an independent study showed savings to the Medicaid program of $240 million per year. And for those who suffer from chronic illness, this new model can literally be a lifesaver.
by doing chronic disease management, we're seeing so many changes in patients.
It's like having a partner help you manage everything, keep things running smooth.
IBM believes the patient-centered medical home works. We believe it addresses the fundamental core issues around what's lacking in healthcare today.
It will result in better clinical quality, better patient experience, greater efficiency in our healthcare system, and help to reduce disparity.
The patient-centered medical home needs to be at the center of any healthcare reform initiative. Adopting this approach all over the country will make life better for patients by delivering better care at lower costs. To learn more about how the American Academy of Family Physicians has joined with other primary care providers, employers, and key stakeholders to expand this new healthcare model for the 21st century, visit us on the web at aafp.org/PCMH.
So I think of the PCMH as restoring to primary care what it was originally meant to be and intended to be in terms of actually caring for patients. What did you guys see in that stood out to you? Obviously, you can probably tell it's pre-Affordable Care Act. With their comments about the healthcare reform needing to be
I'd say seeing the same physician.
Okay.
Yeah, because a lot of times, I know at least me, I'm an Army brat, so I grew up all over the place, and I moved a lot, and when we lived off base doing other stuff, I'd have, TRICARE, and I'd wind up going somewhere, and every time I went to see somebody for, just a general wellness check, I'd go see, 3 different people.
Mm-hmm.
I never saw the same person over again.
Right.
And that was typically at large hospitals. But
Sure. So talk a little bit about what would you anticipate would be the benefits of seeing the same physician?
And every physician doesn't have to read up on you can refresh, but not have to get to know this patient's entire medical history over again.
Yeah.
So I think you'd be able to take a much more systematic approach as opposed to try and figure it out in the limited time you do have with the patient.
Mm-hmm.
Yeah. And I think it facilitates more honesty from physician to patient if you have continual contact, with, someone you have just met. I don't know, I feel like people trust them less.
Mm-hmm.
But if you're seeing the same physician over and over and over again, you're going to trust their opinion, and the physician is going to trust you to do what you need to do.
Right, because trust is built on recurrent interactions and repeated calibrating and then recalibrating based on the results of the application of the advice and the guidance and the treatment that you were given.
It'll also be easier for physicians to see changes over periods of time.
Mm-hmm.
It's easier to pinpoint if something has changed or not than if it's the first time seeing a patient.
Right, that's great insight. Because especially folks with chronic disease, their chronic disease can flare from visit to visit, and if you have continuity with your patient, you're going to be aware that Mr. Jones doesn't look like Mr. Jones 2 weeks ago, and that something's wrong. And so that can be a great help in terms of taking care of patients more expeditiously and more emergently in those situations when time might be life for some of them.
Reducing costs for the patient, I think, is a big deal. Like, when you see different doctors, sometimes they'll run the same test because they didn't get the lab work or whatever, and that's expensive, and that can actually really add up. So I think really reducing costs is a huge thing.
Right. So how many of you have had that experience where you went to one doctor and they said, well, I think this is going on, and let's run some tests to be sure, and then you got sent to another doctor and they said, well, I think this is going on. They ran exactly the same tests 2 weeks later. Or wouldn't you have liked to have eliminated that? I don't know about you, I hate having my blood drawn. It's not that much fun. And so you'd like it I think we'd all like it if our physicians communicated with each other and we understood what was going on with our patients more. Any other thoughts? Okay. Well, the concept of the medical home is really not that new. It was developed back in the 60s when the American Academy of Pediatrics was trying to figure out the best care model for caring for kids with severe chronic diseases, particularly cystic fibrosis, because those children needed infectious disease specialists, they needed pulmonologists, they needed regular checkups to have people call home and see how they were doing. And so out of that awareness of the profound needs across a variety of disease spectrums and the stress that caregivers were under, pediatricians back in the 60s came up with this idea of having these kids in medical homes. And even now you see that where you've got cystic fibrosis care teams rather than a doctor, specific individual that folks will go to. So if you go down to Scott and White, they've got a cystic fibrosis team that sees all these kids with CF, and that's where the model, that's the soil out of which the tree of the patient-centered medical home grew. The term actually is derived from the Future of Family Medicine study that was done back in the early part of this century. Family medicine actually became a specialty in 1971, and then right around 20, 25 years into the development of the specialty, we kind of went through a little bit of an identity crisis like most adolescents and young adults will, and we decided to do a self-assessment, and that was called the Future of Family Medicine Project. And so one of the things that came out of that was that they recommended that we no longer call ourselves family practitioners, or that we no longer call our discipline family practice, but that we call it family medicine. And they also talked about the essentiality of a need for patients to have a primary care medical home, and so that's where the language came from. Philosophically, that was developed over the next several years, and then around 2010 or so, there began to be accrediting agencies that would give different clinics and health systems a PCMH designation based on whether or not they met certain criterion. The most commonly cited one is the NCQA, the National, I'm forgetting what the acronym is, Commission on Quality, and so they actually certify care systems, clinic systems, hospital systems as patient-centered medical homes. And then when President Obama came into office, he began to posit the idea of moving forward with healthcare reform. Some of the early studies that have been done on the patient-centered medical home in terms of patient satisfaction, reduced cost to the healthcare system resulted in the patient-centered medical home being integrated into the Affordable Care Act. And now, as a result of that, there are increasing financial incentives built in to a PCMH designation. So now clinic systems, physicians can actually be paid more by Medicare, Medicaid for having the PCMH designation. And usually what Medicare does, commercial insurance is going to do at some point as well. And so as a result, Humana, Blue Cross Blue Shield, Aetna, they're also reimbursing a little bit more based on whether or not a care provider or a system is designated formally by one of these accrediting agencies as a patient-centered medical home. I know that sounds a little bit complicated, but that's kind of the story in a nutshell, and I'm giving away a lot of hostages to fortune there, but that's a simplistic discussion. So this slide didn't actually show up real well in the handout, but these are basically the 7 essential functions of the PCMH, and they are all they're tied very closely to the nature and identity of what primary care is. So the PCMH emphasizes first contact access. This means that you can call your doctor and get an appointment, or you can communicate with at least you can communicate with your physician in a timely manner to get counsel and advice. The second aspect is patient-focused care over time, so that ties back to the concept of continuity of care. This also incorporates the element of preventative care. It's not just disease-based care where you're coming in for these episodic flares of chronic disease and we're addressing the flare, rather than trying to help you bring under control the chronic disease, say diabetes, that is flaring at the that moment. So we're actually investing in trying to help you manage your chronic, as a patient, manage your chronic disease process, so you have fewer flares, fewer hospitalizations, fewer exacerbations, fewer complications. The third point is comprehensive care, and this is the degree to which the personal physician provides a broad range of healthcare services. And again, this fits well with family medicine because we address the broad spectrum of medical care. We're not particularly specialized in the sense that we focus on cardiology or pulmonology. The fourth point is also closely tied to that: coordinated or integrated care, whereby care is integrated among a variety of health professionals, not just physicians, but we may include mid-level practitioners, specialists, psychologists, counselors, social workers. Point number 5, we have a family orientation. We don't focus exclusively on the individual, but we try to understand the individual in the context of both their family and, number 6, their community. How does their family impact their health? What choices that the family makes negatively or positively affect the health decisions that the individual patient is making? What does the community, how does the community affect the health choices that the individual is making? And how do we begin to help the community make better choices for itself, which then feeds back on the health of the individual members of the community? And then finally, cultural competence, which goes back to the biopsychosocial model, and reflecting on all of the different ways that human beings, the diversity within a single human being, and the health benefits that come from addressing those as well as being aware of the unique aspects of belonging to a particular culture and how that culture views health. Hispanics view health differently from Anglos. Anglos view health differently from African Americans. Vietnamese view health differently from Anglos, and so forth. So in 2007, the American Osteopathic Association, the American Academy of Family Practitioners, the American Academy of Pediatrics, and the American College of Physicians, which is the internal medicine licensing body, came up with this definition for the PCMH. It involves these, what's called the joint principles, these 7 points. It involves a personal physician, physician-directed medical practice, whole person orientation, coordinated and integrated care. There are ongoing quality and safety measures evident within the system or within the clinic, tied to EBM as evidence-based medicine, and support systems built into an electronic health record that help you make decisions about how to care for the patient. So for example, in our electronic health record system, if a patient hasn't had, say a diabetic hasn't had their hemoglobin A1C, which is a 3-month measurement, retrospective measurement of their blood sugars, the system will pop up and say, this patient is due for this. And so we don't have to do a chart search or a chart review to see when the last lab was done. The computer does it for us automatically and brings it to our attention. Underneath, again, the quality point, voluntary QI quality improvement processes are met, patients' expectations are met, so we're constantly assessing the effectiveness with which we're meeting patients' needs. Health information technology is used appropriately, and then currently the recognition process for the PCMH is voluntary. It's not obligatory, but again, the government is tying financial incentives to being designated as a PCMH, so there is certainly some incentivizing going on. The other 2 elements: enhanced access and then appropriate payment. Payment is kind of a big issue right now. The payment system for the patient-centered medical home is still evolving, and it's not where people want it to be yet, so there's a lot of debate about whether or not it's actually financially feasible yet to be designated or to pursue designation of the patient-centered medical home, and that's where a lot of the debate is right now. Yes?
So how does that differ so much from other medical facilities, and how the billing and payment is done?
Are you asking how does the patient-centered medical home model differ from the sort of what was before?
Correct.
The idea here is that it puts the patient back at the center of the care process. So we're always asking ourselves, how do we provide the best care for Mr. Jones at any given point in time? What's going to make his care better, and how are we going to improve his overall health. Answer from a variety of different angles. So we want Mr. Jones to have one doctor like you talked about. We don't want him to go see, every visit he's seeing a different provider who's got to reinvent the wheel because they don't know him. And then they want that physician to be able to direct the care process for him. So that physician is going to be making referrals, but also getting information back in a timely fashion from those to whom he refers the patient, so that he has some idea when Mr. Jones comes back to the office what the cardiologist said in that visit 2 weeks ago. He doesn't have to go searching for the records as we still do now. And I think both Lauren and I have sat in offices saying, I don't have the record from your cardiologist, and we've called their office 3 times, and I'm sorry, they're not getting it to us. I guess we'll just reschedule today, and maybe we'll bring you back in 2 weeks, and hopefully we'll have the record then, and we can talk a little bit more about what he said, because I don't know.
Sometimes it seems easier to do brain surgery than to get medical records from another institution.
Yeah.
I mean, it's crazy the firewalls that are there and how hard it is.
So that is a source of great frustration, or has been. It's improving. It's not where we want it to be. And then we've got whole person orientation. You guys, I guess I went to Baylor from 1995, and we used the Welcome Week wheel. I'm assuming you're still using that. So there you go. The Welcome Week wheel gets incorporated in the patient-centered medical home. And then we have coordinated and integrated care. So we're pulling different care providers like I talked about. We're using social workers to help meet with Mr. Jones to talk about his end-of-life wishes and whether or not he feels like he needs to be in a care facility, or whether his family's going to be able to take care of him. If so, who's going to make the medical decisions for him, who's going to partner with him to make medical decisions for him. So rather than you as the physician taking that additional time to try to hunt down all those details, somebody else is hunting down all that information, pulling it together and presenting it to you in a nice package. So you can say, oh, I see your oldest daughter's going to be your medical decision maker. You've decided to try to remain at home for the time being, and you'd also like me to refer you for home health care. Well, there's a lot of work that goes into finding that information out. And whereas we as physicians may have been doing that previously, now we're able to pull other care providers in to get that information for us, so we have it point of care for the patient, and we don't waste our time, and we don't waste their time so much. Quality and safety measures, that's accountability, basically. Are you doing the right thing for your patient, and how do I know that? Then enhanced access, can the patient get in to see you? Are there barriers? Do they call in and get a digital recording that says, please hold, and they hold indefinitely and then get hung up on? Or do they get transferred multiple times? Are there appointments available when they need them? Are the digital health care providing same-day appointments? Those kinds of things. And the final thing is, are people getting reimbursed for providing those services? Because if you have social workers providing those services for folks, finding out who their power of attorney is, what their end-of-life wishes are, but they're not being paid to do that, and that creates some significant issues. So those are the joint principles of the PCMH. So within the Affordable Care Act, Patient Protection and Affordable Care Act is actually what the official title is. It's now the ideal practice model. So, and there's still a lot of debate about what is this going to look like, how is this going to be funded, but it's there, it's part of the Affordable Care Act, and it's not going to go away for a while. And the good news is that there's so much work to be done in designing it and building it that you guys are going to get to play a part in that if you decide to jump into primary care. So, and the whole point of this talk is so that you have a little bit of an idea of what you're jumping into before you do it. Any questions at this point? I'm going to wrap it up.
What would you change?
What would I change about the system? Mm-hmm. I really like the care team model. I would really like to have the patients that I know are sickest have somebody, not necessarily myself, calling them on a regular basis, checking in to say, Mrs. Jones, how's your blood pressure today? How was your blood sugar? Are you feeling suicidal? When was the last time you had a hallucination? How's your relationship with your daughter? I know that's been a significant point of stress for you. You've been in on multiple occasions, and that seems to really impact your depression. How's that going? So if you're able to have folks to help care for all of the different aspects of the individual, you can reduce the complications that they have from their disease process. and in the process, you're providing better care for them. We as physicians can't do that. There are so many patients, and you saw the map, you saw the dearth of primary care physicians, and there's a lot of people out there that aren't getting real good care. That's why we have so many ER visits. That's why hospital bills are so high, and that's why we're working on trying to reduce the number of hospital admissions and the number of ER visits, and the cost that brings to the system. So it's kind of a long answer.
Dr. Hess has really helped me understand. Well, it's one thing to read about it as you have there. Or maybe I'm jumping in too soon, but he's been able to help communicate, I think, some enthusiasm and hopefulness, which is good. We need hopefulness in medicine, and I think I'm getting ahead of you, Buritt, but
oh, we're done.
I appreciate his ability to help us realize this is good. You know, change is good, and this is the time to jump in, and this is a time we can really make a difference and help shape the healthcare system. And it's pretty exciting to be a part of.
Mm-hmm. It's an exciting time to be part of the American healthcare system. There's lots of change.
So would you like take on a new team member that would be solely responsible for patient contact, or would you split their responsibility over like the entire team?
Well, we would probably delegate that. That role could be filled by a social worker. That role could be filled by a case manager, who may or may not be a social worker. There may be an RN, there may be an LVN. But there would be a care team assigned to your patient panel as a physician. It would be reviewing your patients before they came in, identifying gaps in their care, identifying where the records were that needed to be pulled in from what specialists they saw, so you had that at your fingertips when you went in the room to see them at 2:15 this afternoon, rather than getting in the room and saying, I went to the ER last week, and I saw the cardiologist 2 weeks ago, and I was hoping you could tell me what's going on. And you say, oh, you did? Give me just a second. I'm stepping out and saying to your nurse, okay, he was at Prob 2 weeks ago in the ER, or whatever I said. I need those records, and I need the cardiologist records too. Did you know that he'd gone to the ER? No, I didn't know he'd gone to the ER. Oh, gosh, okay. Well, we need to find out what happened, because he said he had some of his medicines changed.
I've just told this, trying to communicate the story of how frustrating it is, knowing, you've seen the caliber of the physicians that work at the Family Health Center, and how frustrating it is to have exhausted so much mental, psychic energy that it takes just to gather the data before you even laid hands on the patient, and just how frustrating it is to spend so much time doing those things.
Yeah. So that as opposed to walking over and saying, okay, Mr. Jones, saw you were in the ER yesterday. We've got the records. I know they decided to discontinue your metoprolol because your blood pressure was 96/56, and you were pretty dizzy, weren't you? Yeah. Well, the good news is that when you saw the cardiologist 2 weeks ago, your stress test showed that you didn't have any significant heart disease. However, because your cholesterol was, your total cholesterol was 256 and your LDL was about 180, I think maybe when we want to talk about some cholesterol-lowering medication, you're 46, I'd like to see live a little bit longer than 20 or 30 years, which you might have given your lipid profile. So we're going to do that today, and we'll watch your blood pressure and see if stopping your metoprolol was the right choice ultimately, or maybe we just need to back off it a little bit for you. So, it's totally a different conversation
than flipping around, trying to find, and at this point in time, we're looking for paper and clicking. It's not just, not just paper records, but trying to get to the.
Right. So you're more satisfied as a care provider. The patient's more satisfied. They're better taken care of because you know what's going on with them, and you're able to speak to that in real time. So you're a better doctor.
Excellent. Thank you. Next week, Jasmine Holiday, the social worker at the Family Health Center, is going to be here. And I also want to do a field trip with you guys, okay? So I want to figure out how we can all go over to the Family Health Center to be over there at the main site one of these times. And I don't know if we want to meet over there, or I don't know how we'll coordinate all that. Would y'all be able to meet at 3? Who has classes right before this? Okay. So it's under 15 minutes. You just go right over and cut over. So we can meet here. It wouldn't take more than 30 minutes, probably 30 or 45 minutes. I wanted to see the pharmacy.
Oh.
Yeah.
So anyway, we'll talk about that later, but just plan on in a couple of weeks, we're going to have a field trip to the Family Health Center, okay? Sound good?
Sounds good.
And I also, we talked about,